A surgeon can save your life or take away the one you already have. Here's the question almost nobody asks before they pick up that pen. Not can I survive this surgery, but can I survive what comes after it? Today, 5 operations that quietly wreck more lives than they fix in patients over 65. And the exact questions that can keep you off that list. Most of us carry the same quiet assumption. If a doctor says you need surgery, the conversation is basically over. The white coat, the scheduling desk, the consent form, it all moves so fast that saying wait feels almost rude. But talk to enough geriatric specialists and a very different picture emerges. Patients who walked into a hospital and never walked the same way again. Patients who traded a few months of discomfort for a year of recovery they never got back. The pattern isn't that surgery is bad, it's that older bodies pay a completely different price for the exact same procedure than younger ones do, and for a long time, medicine didn't build that difference into the plan. Here's a simple way to picture it. 2 cars go through the same crash test. One just off the assembly line, one with 200,000 miles behind it. Nobody expects identical results. Yet for decades, a 40-year-old's body and a 75-year-old's body were run through nearly identical surgical playbooks. Same anesthesia doses, same recovery timelines, same expectations. That's finally changing, but not everywhere and not fast enough. What actually happens under anesthesia in an older body? The heart works harder to compensate. The liver and kidneys clear medication far more slowly. The lungs take longer to recover full function. And the one that surprises people most? The brain. A confusion and memory disturbance called postoperative cognitive dysfunction, POCD, can linger for weeks, sometimes months, and it shows up far more often in patients over 70 than most. People realize, important distinction, age by itself isn't the danger. Frailty is. Frailty is a measurable drop in the body's physical reserve, its ability to absorb a big physical hit and bounce back. A vigorous, active 80-year-old can sail through an operation that would be genuinely risky for a sedentary, multi-condition 6-8-year-old. Roughly 4 in 10 people over 75 show measurable frailty that climbs towards 6 in 10 past age 85. Which brings us to the real question this whole video is built around. Not will I survive the operating table, but will I survive the 6 weeks after it? 1 open heart bypass surgery in frail patients. Traditional coronary bypass means stopping the heart and running blood through a machine. A huge undertaking for anybody, but especially one already running on a thin margin. In frail elderly patients, research points to complication rates, stroke, kidney injury, extended ventilator time, in the range of 30–40%, with mortality within the first month reaching as high as 15% in the highest risk group. The alternative worth asking about, catheter-based procedures like TAVI, which can treat certain heart valve and artery problems without stopping the heart or opening the chest at all. 2. Elective spinal fusion for chronic back pain. Back pain in your 60s and 70s is nearly universal. And for true emergencies, like a compressed spinal cord threatening paralysis, surgery is not optional. But elective fusion for ongoing pain is a different story. Studies on patients over 65 report complication rates north of 40%, including blood clots, hardware failure, and a domino effect called adjacent segment disease, where the spine above or below the fused section starts to break down under the new strain. Multiple studies have also found no meaningful long-term pain advantage over physical therapy and targeted injections. Just a much steeper risk. 3. Major cancer resection surgery. This is the hardest one to say out loud, because the instinct is always cut it out now. But the actual goal of cancer treatment is more years of good life, not just tumor removal. A procedure like the Whipple for pancreatic cancer can run 6–10 hours. In an 80-year-old with existing heart or kidney disease, the tumor might come out clean, and the patient can still lose their life to complications weeks later. What surgeons call a futile surgery. Data compiled by surgical researchers found that roughly 1 in 5 elderly patients undergoing major cancer resections experience failure to rescue, a complication their bodies simply didn't have the reserve to survive. For some patients, radiation, targeted drug therapy, or careful monitoring can offer more good years with a fraction of the risk. 4. Elective joint replacement with multiple health conditions. To be clear, hip and knee replacements are among the most successful, life-changing procedures in modern medicine. For the right candidate, the risk climbs, specifically for patients over 75, juggling 3 or more serious conditions: heart disease, diabetes, obesity, where blood clot risk, including clots that travel to the lungs, rises sharply. But because these surgeries are elective, there's time to prepare. That's where prehabilitation comes in. tightening up blood pressure, blood sugar, weight, and cardiovascular fitness before surgery. The same way you train before a race. Hospitals running formal prehab programs for high-risk seniors are seeing meaningfully lower complication rates. 5. Emergency abdominal surgery. Nobody schedules this one. A ruptured appendix or perforated bowel decides for you. But understanding the danger now, while calm, changes how families make decisions in a 2 a.m. crisis. Mortality for emergency abdominal surgery in patients over 75 runs 30–50% in severe cases, largely because a body under sudden trauma ends up fighting on multiple fronts at once, which can spiral into multi-organ failure. The 4 questions to ask before any major surgery. 1. What happens if I wait or don't have the surgery at all? If nothing dangerous changes in 6 months, you likely have time to think it through. 2. Is there a less invasive option? Catheter-based, robotic, or non-surgical? SAN. What does recovery realistically look like for someone with my health profile, not the average patient? 4. What's your personal complication rate for this exact procedure in patients over 70? A surgeon confident in their outcomes will know this number and share it without flinching. Consider a composite case pulled from real clinical patterns. Call him Walter, 72, a retired school teacher. 3 cardiologists told him he needed open-heart bypass for a blocked artery. Walter wasn't scared of surgery itself. He was scared of what happened to his brother 2 years earlier, who came out of a similar operation confused, exhausted, and never fully returned to who he'd been before. That memory made Walter slow down and ask for a full frailty assessment and cognitive baseline before agreeing to anything. What he learned. For his specific profile, an aggressive medication plan paired with structured cardiac rehab produced comparable 5-year outcomes to surgery. He chose the non-surgical path. 3 years later, Walter's back to leading nature walks for his grandkids' school group. A surgical recommendation isn't a verdict. It's the opening move in a conversation you're allowed to steer. Age isn't a weakness. Being informed is the advantage. Being asked the right questions is what separates patients who bounce back from patients who don't. Which of these 4 questions would you ask first? Drop it in the comments. And if this helped you get ready for a conversation with your own doctor, subscribe for more explainers that cut through the noise.